Okay, so Sandeep, I think we can start. You should be able to share the screen now.
Yes, sir. Can you see my screen, sir? I've already shared. Can everyone see?
Yes, sir.
Yes, yes, Sandeep.
Yes, we can. Yes, we can.
Can we start, sir?
Yes, please.
Yes. So today we are going to discuss about indication, background, and history of like hematopoietic stem cell transplantation. So objective of this discussion is like to know definition of transplant and types of transplant, source, and main is about the indications. And further, we'll little bit will see about history and main organization who all involved for this transplant. So it's also can be like HCT as a call can also call like different names. The hematopoietic progenitor cell transplant, hematopoietic cellular therapy, so bone marrow transplant, hematopoietic cell transplant, peripheral stem cell, blood stem cell transplant, and umbilical. Different names are there. So generally, we'll call it a hematopoietic cell transplantation. So definition is like the process by which non-functioning or deficit marrow or malignant cells are eliminated. The main here like indication like we have to eliminate the affected marrow by chemotherapy and radiation therapy, and we have to replace it by the healthy hematopoietic cells. So that is the main indication here. Like main thing is about the indications, definitions. So the transplants are developed like gradually over last 4 to 5 decades, found to be an effective treatment for many malignant and non-malignant conditions, and also serves as a medical treatment for many conditions. So this image just I have shared like how the cell divisions will happen and what is hematopoietic stem cells. So hematopoietic stem cell can be self-replicated and it matures into different cells. So some stem cells can produce other stem cells, and the stem cell can change into different cells. And this image like I have shared like especially for nurses to know like because main thing like in nursing studies in nursing education we will see only RBC's lifespan, but here like neutrophils, eosinophils, eosinophil like all the cells I have mentioned, and neutrophils like it will be in once it matures like it will be 7 hours in our body. It is more about immune defense. And other cells also have mentioned like B cells or T cells are there. So B cells are more about antibody production cells, and B cells are and T cells are more like it will be lifelong. It will be with us like it's a immune cells. And platelets inside the body it will be 8 to 9 days, and RBCs will be like 120 days. So what is the goal for like this transplant? The main goals is eradication and replacement of the disease marrow, and eradication of tumor cells and rescue the marrow, and replacement of non-functioning marrow, and replacement of deficit immune system. Sometimes the immune system issues are there. That time also will go for transplant. So there also replacement will happen. And types of HCT. So there are 3 types of HCT like autologous, allogenic, and syngeneic. So what will happen in autologous? In the autologous, the donor will be the same person. So the patient will receive the first the bone marrow will be rescued, and the patient will receive the chemotherapy, and again the patient is going to receive the same bone marrow. In the allogenic, the person will be different person. So there may be related or unrelated. The person will be different. And the syngeneic, it will be like identical twins will be the syngeneic transplant will be done. So again, like about autologous, will be used patient's own HPC. And in this here, like the lower transplant related mortality will be there, and no GVHD will be there, and more rapid immune recovery will be there, because that we are not giving marrow from some other person or somebody, so there's no more chance for GVHD, and the recovery will happen very fast. The sources will be like peripheral blood collection will be there, and bone marrow collections will be there here. So this is the image like the autologous. The first is like bone marrow collection processing will happen. will cryopreserve that marrow, and patient will receive the high dose of chemotherapy, and again the patient will receive the own bone marrow, and it has to be started engrafted. This is called an autologous transplant. So common indications for autologous transplants are solid tumors, hematological malignancy, and investigationals. So high risk neuroblastoma, sarcoma, recurrent wisp tumor, brain tumors, this all will come in solid tumors. Hematological Hodgkin's disease and non-Hodgkin's lymphoma, and autoimmune disorders and rheumatological disorders. This is all the indication for autologous transplants. So what is allogeneic transplant? Already this also we have briefly saw. So allogeneic transplant is infusion of marrow from the donor source after immunosuppressive cytotoxic chemotherapy or radiation therapy. So the patient first will receive the chemotherapy or radiation therapy, then the patient from the donor patient is going to receive the marrow. So again here like few 4 points I have mentioned, like matched sibling donors will be there, matched unrelated donor, mismatched related donor, and umbilical cord blood can be used. And this image is like the patient is going to receive the first radiation and chemotherapy, and from the healthy donor, we are going to receive the bone marrow, and we are going to infuse to the patient. This is called allogenic transplants. The common indication for allogenic transplant is hematological malignancy and hematopoietic disorders. So hematological malignancy, acute myelogenous leukemia, acute lymphatic leukemia, general myelomonocytic leukemia, chronic leukemia, non-Hodgkin's leukemia, and myelodysplasia. And hematological disorders are like this is the where very like in developing countries we are especially in our transplant units we are dealing sickles and anemias, Fanconi anemia, thalassemia, aplastic anemia, diamond-black anemia, and proximal axial hemoglobinuria. So among this like thalassemia and aplastic and sickle cells we are seeing the more patients. And immunodeficiency, the severe combined immunodeficiency and Wiskott-Ulrich syndromes, and sometimes like genetic disorders will be there. So these are the main indication for allogenic transplant. And this image, like you can see, like about syngeneic transplant. The first image is showing about the allogenic transplants. So the donor is giving bone marrow to the patient. Here, like this is the autologous transplant. The patient himself has to rescue his marrow, and patient will receive. This is about the syngeneic transplant. So it will more about identical twins will use for the syngeneic transplants. The sources of HPC now. So the sources are like from the bone marrow we can take the HPC, and peripheral blood stem cells also will get with an umbilical cord. So these 3 sources are there for the HPC's collection. So about this detail we'll go for next slides. You can see what is bone marrow. So bone marrow is a soft spongy tissue will be there. Interior the long bones will be there. And in adult patient, approximately 4% of the bone marrow will be there in adult patients of the body weight. And this is about the peripheral stem cells. So peripherally, we can that is called a PBSC. Like peripherally, we collect the stem cells. But here, like the disadvantages is like in the peripheral blood, like inadequate numbers will be the stem cells. And sometimes what will happen, what is expected cells we won't get, like multiple times we may need to get the collections. But here only the major problem in the peripheral blood is there will be high risk of GVHD, because there will be in a peripheral blood there will be a more mature T cells will be there. So this will be high risk for patient to get a GVHD. When we are looking into bone marrow, so we won't get more mature T cells we won't get. So there will be the risk of GVHD will be lesser in bone marrow compared to especially the peripheral blood cells. So umbilical cord is it is treated as a medical waste, and again here the disadvantages is like the quantity of the stem cells you won't get, especially the recipient is bigger child, the quantity will be not sufficient. So the overall conclusion is like the bone marrow will be the safest stem cell. So the risk of GVHD will be lesser, but the engraftment the faster engraftment will happen in the peripheral stem cell, what we're seeing. But in the peripheral stem cell, always there is a risk of GVHD, high GVHD. The process of like a transplant. So there will be a pre-transplant phase, peri-transplant phase, and there will be a post-transplant phase will be there. So in the pre-transplant phase is more about planning and preparation for the patient. And peri-transplant is a acute phase of a transplant. Just patient underwent goes to transplant acute phase. And post-transplant is like a late and longer term like complications we're going to see in the like post-transplants. The post-transplant, like pre-transplant, we're going to work off a few things, because I did not mention a lot of things are there. The basic important points I have mentioned here. So HLA is very important in the pre-transplant phase, and recipient and donor workup will be there, and patient and family education and informed consent. So these all things will come in more about the pre-transplant. So if sometimes it's complete match is there, HLA we're going to use. Sometimes if the half match is there, again additional workup will go, like DSA. We may need the patient may get the donor specific antibody workup. We may need to do the haplo conditions, and same thing like in our donor workup. Next slide we'll discuss about the donor workup and patient workup. The patient workup, like may think about history collection will be there. In the history collection when the patient was diagnosed for the thalassemia. So till now, how many patient has gone to how many transfusions, and how frequently patient is getting transfusions, and patient all the health histories, everything we are going to go in the history collection, including the family tree. So who are the carrier was there in the family, how many children was there, this all thing will go in history collection. And we are going to see the physical examination of the patient. In the physical examination is more about height and weight, and is more about here spleen and liver. We are going to concentrate more on physical examination. And again, the patient will go to counseling sessions, and HLA will do, and investigations will do. There will be a lot of investigations will be there, and blood transfusion. So sometimes we'll go through a hypertransfusion, super transfusion. If patient have big spleen, we'll try to keep the higher hemoglobin for patient. And aggressive chelation therapy will be there on patient, and patient will be on hydroxyurea. And also we'll go through the history collection of the vaccination history of the patient. If patient is underwent splenectomy, we may look into pneumococcal vaccination as received the patient, and all the basic vaccination history also will go. And in the preparation, as I told previous slide, we'll see the consents also. We'll take the consent. And investigation wise, more will look like ultrasonography will do, and weight and height, and LFTs will do, complete blood count, and ferritins will be there. Again, here I'm a lot of speaking about the thalassemia condition, and it will depend on different conditions. So if they're going to for aplastic or leukemia, they're not going to look for the ferritins, everything. So again, the biochemistry investigation and PTA PTT will see, and IHA tests if the patients have the different blood group. So we may need if the major mismatch or bidirection mismatch are there, we'll go to the IHA tests will see. And serology tests are very important for patient, and CMP and stool TPHA, and we'll go for Montague studies. For donor, again, height and weight is important, and date of birth. So approximately the donor weight, we're expecting the recipient half of the weight we'll expect for the donor weight. If still smaller child, sometimes we may need to do the pre-deposit for the patients. And blood group, as I told already about IHA status, will show the blood group, and HP electrophoresis also we see. So just to confirm, is it patient is donor is a carrier or not, we'll go to the HP electrophoresis. And CBC, if the female child is a bigger, more than 12 years, we'll look for the pregnancy test also we'll see. And serology, Montague, and CMB and coagulation profile. And sometimes we may need to do the serum ferritin test also. And main thing here, if the thalassemia transplants are seeing, and we'll see, if again here, if we are going to do the bone marrow harvest, then the donors will keep on the iron supplement. For the peripheral stems, we won't keep more about iron supplement. If bone marrow patient is going to there, then I will keep them the iron supplement. During the transplant, peri-transplant, more about here, the patients will start with a condition regimen, and after finishing the condition regimen depend on the protocol, which protocol we are using, and what is the Apollo case or complete match, it will depend. And here a patient will receive the bone marrow, HPC infusion patient receive on 0 day. And post HPC receive the main few things we are going to see, like the patient will go to neutropenic spaces. Patient may get the infections, organ toxicities may get the patient, like liver toxicity, renal toxicity, like the cardiac toxicity, lung toxicity patient may get. And again, patient will get started the engraftment process. So during the engraftment process, patient may have the engraftment fevers, patient may go. And acute starting stage, patient may have the acute GVHD. Once these all things pass, we will immediately plan for the patient get grafted, patient everything is fine. We'll plan for the discharge and discharge education review. So this all things are the important points what will come during the transplants. So post-transplant and long-term issues will be sometimes patient may come again with some viral infections may get the patient, and patient may get the viral infection. Sometimes like late patient may get rejection, like immune reconstruction may happen, and patient may have like a chronic GVHD. The chronic GVHD again defined differently. So sometimes they'll tell after 6 months, like after 120 days of thing, patient may get again a chronic GVHD also may get. And main long-term problems will be their post-transplant patient about infertility. So the busulfan what we are using, that may infertile for the females, and the cyclophosphamide, high dose of cyclophosphamide may lead to infertile in the males. And sometimes again long-term complication, the growth also, the growth may hold it, they may have some issue, they may need it, the endocrine workup may be needed at time. So there will be issues with the growth. So history like 1891, the marrow first initially that was given orally. And 1958, Lowe's like studies was came and spleen was protected and delivered radiation therapy and infusion of marrow was done. And 1957, human application of HPC was done. Engraftment happened, but again outcome was poor. And later 1958 and 60s, HLA was identified, and first successful transplant was in 1968. And 1970 and early 80s, Hickman support was and supportive care was identified, and autologous transplant was done in 1980 and 90s. And national bone marrow donor registry was came in same period, like 1980 to 90s that it was started. And 1988 first like umbilical cord beta transplant was done, and 1990s the DLA and advanced molecular HLA was introduced. The main organizations what involved in these transplants are like the National Marrow Donor Program and FACT, CIBMTR, and PBMTC and FDA are there. So about our like C2C and bone marrow, like the Sankalp and ATA, like more we are involving about the FACT JC and CIBMTR. This both organizations we are involving, and CIBMTR for all the transplant information we are uploading in the CIBMTR. Okay, thank you. So for me, time was given 30 minutes. That's why I tried to finish fastly.
Thank you, Sandeep. So